Myself, Amaz here. I'm a clinical embryologist and lab manager here. So I'll be taking you a quick class on the semen preparation and semen analysis. So how many of you are aware of how to do a semen analysis? Though it is not your forte, but since you are going to deal with infertility patients, so you need to know how we do, because in absence of the technician, or just to verify that whether uh, the exact count or motility or morphology is the same as what the technician is being given. So because based on that only you'll be deciding your further treatments. So the semen analysis, the purpose of doing semen analysis is to see whether the count and count, motility and morphology of that functionality of that test is. So what does it consist of? Semen is consist of a suspension, what was suspended with a lot of hormones, a lot of other cells, that is pus cells or any Sertoli cells or epithelial cells. So how do we differentiate between the other cells and the sperm cells? Sperm cells have a tail, as we all know. So both the size of these cells are more or less the same, but comparatively the sperm cell is much more smaller, and majority right now nowadays we have something called CASA, or AI enabled analyzer. So it does have a different perspective of detecting the sperm. So even if it is a round cell, if the sperm, patient is azoospermia, it will count it as sperm cell. So it is always to go with the, it is always best to go with the manual counting of semen analysis. So it is actually it is a fluid which is secreted by many accessory glands. So why semen analysis? As we all know that we are going to treat the patient for self-fertility patients. What it can provide information: the sperm production capacity, the patency of male duct, the function of accessory gland, and ejaculatory function. So why sperm preparation is needed? Anyone? You have OITA that you will be planning, then you will be asking them to go for a time dating course. So why is it necessary for an IUI or an IVF to have a sperm preparation to be done? Because it is essential for us to filter the sperm out of other things. So if you are going ahead with IUI, you have this hormone called prostaglandins. So what it will does, once it enters the uterus, because you are going through the horse and you are going to deposit the processed sperm inside the uterus for you to do the IUI, and further it will proceed in the conception. So when there is a prostaglandin is present in that prepared sample, the uterine will get contracted. So once the uterine get contracted, you will not have a smooth flow of that uterine hostile environment for it to go and conceive, go and fertilize the oocyte which is waiting. So one that is essential for IUI. For IVF it is essential because it has to undergo capacitation. So capacitation is nothing but maturation of sperm internally. So when we do the processing of these sperms, it goes through a proper channel. We have something called gradient method. So in that gradient method, what it will does is, consider you have a lot of balls in a basket. So in the basket you will have small, in between the balls you will have small holes, right? Similarly, the void between the balls is as small as these sperms. So whatever the bigger size than that includes hormones and everything, will stay up only. So we have something called 80% and 40% of gradient that denotes the density of that gradient. So the 80% will be higher denser, and the size of the ball will be smaller. So the pore size will also be smaller. So the 40% gradient will have beads. That is, when you observe in a microscope, it will look like a bead only. So you will have the bead of 40% above this layer of 80% that we will be looking forward. So that is how, we will also have a demonstration on how we do the semen analysis and semen preparation as well. So this factor to be considered during semen analysis is condition of collection, because the male partner has to feel the ambient environment in order to collect. So a private room near to the lab into a clean white mouth, that has to be collected in a non-toxic plastic container, and it has to be labeled with name, identification number, and date and time of collection by the patient itself. Instruction given to the patient regarding collection that they should not spill the sample before, while they are ejaculating. They have to collect from the starting drop till to the last drop, because the initial drop consists of rich concentrated sperm. The initial spillage will cause the reduced volume, so you will give a biased treatment to the patient if you have not known that. So we have to give them a proper instruction about the collection. And typically we will not be advising for the home collection, because there are ethical things that has to be followed, that we might not know that the sample is belong to that patient. So if he does, we have to get a consent that with the witness of their wife, that the sample which is brought to the lab is belong to that patient only, with the identification of either Aadhaar or anything. It has to be self-attested. So at home collection, there is a way of doing it, because when you are giving the container, you have to tell the patient you should not use lubricant, you should not use any powder-free glove or condom, because all these are spermicidals. So they have to masturbate or coitus interruptus, but when they are collecting it, they have to collect the whole sample. Once they have collected, the proximity between the home and the center should be less than 30 minutes of travel. So once they have that less than 30 minutes of travel, as soon as they are done with the collection, they have to wrap up with some foil or a tissue, and they have to put it inside their pockets, not in the bags or not in the hands, because we have to maintain the closest proximity to the temperature. And that has to be recorded at the time, and they have to deliver the sample within 1 hour. Minimum is 30 minutes, and consent to be taken. And the abstinence should be 2 to 7 days. It is advised for 2 to 5 days of abstinence. For additional sample, abstinence should be constant, like 2 to 5 days. And higher abstinence decreases the motility, because of high accumulation of sperms, and when considered beyond 7 days, you can see a lot of immotile sperms. So the lower abstinence will give you a decreased count. Those initial part, as I have told you that what it consists of, the initial and last part. And the recent, like if the patient is having fever, jaundice or surgery, it is advised not to go for a semen analysis the moment they are having, because it will give you a biased report. So in the semen analysis, we have to consider two types of examination. One is macroscopic and microscopic. Macroscopic is nothing but the liquefaction time that we have to see. That should be somewhere around 30 minutes to 60 minutes. Within that time period, it has to be liquefied properly. Liquefied is nothing but it has to be a discrete droplet. It should not be sticky or forming a string-like structure. So the minimum time is 30 minutes and the maximum is 60 minutes. Even though it is not liquefied, then it has to be noted that the sample is viscous. According to that, you have to do the further processing. Or you can give the antioxidant as and when you are prescribed. And the appearance, we have to note it down, because that also denotes what the patient is going through. If it is opalescent and homogeneous, sometimes the color also we have to note that whitish to grey, red to brown, or yellow to yellow. So yellow denotes that patient is having some, they must have, after ejaculation they must have collected urine as well, or retrograde also could be an issue. Or if the patient is having the brown kind of semen collected, then the patient is having some infection or hemospermia that leads to the presence of RBC. The whitish to grey is what we require for the normal semen analysis. And the viscosity, as I have told you, that it should leave the drop by discrete drops. If it is forming the thread-like structure even after 60 minutes, 2 centimeters, more than 2 centimeters, that sample has to be called as viscous sample. And the volume is 1.5 ml as per 2010, and as per 2020 guidelines it is 1.6. and pH should be somewhere around 7.2 to 7.4. So when it comes to macroscopic, we have sperm count, concentration, sperm motility, and sperm morphology, and the other counts of sperm cells and epithelial cells as well. So the number of, this is the macro chamber that you will be looking here. So it has a lid which has a very minute scaling, which is of WBC chamber. In that only we will be calculating the whole count of we will be calculating the count of the sperm and the sperm concentration and the motility as well. So how do we calculate this is that the sperm will be constantly moving from one box to another box. So we will be alternatively counting 1, 3, 5th row, and minimum of 3 rows and maximum of 5 rows we can count. If you are finding in this row like around 50, and the next row, this next row is, third row is around 55, and the next row is 65. Add all 3 and divided by 3 is your sperm concentration per ml. For total ejaculate, that concentration into the volume is the total ejaculate. This is how it will look. So it will be constantly moving. So we have this cell counter to tap on whenever, as and when you are seeing in the chamber. So majority we will prefer one triangle of either sides, so that even if a sperm moves from this side to that side, we will not be counting 2 times. So the sperm motility is categorized into 4 parts. One is rapid and slow, that is considered to be progressive sperms. Non-progressive is nothing but the sperm will be in a place or circling in a small motion or showing a light twitching kind of thing, that will be considered as non-progressive. Immotile is no movement, it will be static. That doesn't mean that it is dead. It has lost its motility activity. To confirm that motility percentage, we have to do the vitality test. So you can refer both WHO 2010 and 2020 for your reference value. So this is how we confirm that whether the sperm is vital or not. If the stain is taken by the sperm, that means it is dead. If it is white, that means the membrane is still intact and it has not absorbed the stain. So we have this morphological assessment that indicates the cytoplasmic droplets. So this is how you will see in the morphology that tapered pyroform. You must be seeing the outside report and the fertility center report. Outside report they will be giving 60%, 70% normal forms, but they will not be categorizing in all these formats. They will be just generally giving, okay, this is the percentage. But what we are doing here is we are giving a strict morphology assessment that is having a TZI index, teratozoosplomic index. So that actually gives you a precise information on what kind of defects the sperm is having and what is the percentage of it. That could be only head defect, that could be a combination of head plus midpiece defect, and that could be a combination of all 3. So the categorizing that, we have something called TZI index that we do, and we have to assess this morphology, we have quick diff staining kit or quick diff, and another one, the rapid morphology test. So this is a practice slide to assess yourself that whether you are giving a right morphology assessment or not. So can any of you tell me which is the normal looking sperm? Obviously it is distinctly visible that it is abnormal in that. So you have a separate worksheet in the WHO manual where you can see all these diagrams, and you can guess that it has to be oval shape. The midpiece has to be thin, not thick. It has to be moderate, not too thin, not too thick, and the tail has to have the 3 length of the head and midpiece combined. So for me, the normal form is So you will have that kind of assessment in your WHO manual where you can assess yourself that you are doing a proper morphology assessment or not. So this you will have multiple defects as well where you can see a bulging of midpiece and pyroformed head defects. And you have multiple defects where you will not have the extended tail, midpiece is thick, and the head is also not oval. So this kind of practice you will have it in WHO manual. So this is the reference value of 6th and 5th edition, 2010 and 2020. So as I have told you why the semen preparation is necessary, because it has a decapacitating factor that will not allow the sperm to get mature inside. So naturally what happens when the partner ejaculate inside the, deposit the sperm inside the, on the spot, it actually liquefies. So through this journey, the capacitation will take place. Because of the pH the vagina is possessing and all the other factors that actually induces the sperm to have the capacitating factor, and once the capacitation happens, the sperm will be rapid progressive. So it will when it is in a solid state or the semi-liquid state, it will not have that kind of movement in and around. When it gets capacitated, the velocity of that sperm to swim, to go forward, increases by 5 times. So by doing the semen preparation, we are avoiding leukocytes, bacteria, and debris and non-germ cells, local hormones like prostaglandins, eventually the negative impact of spermatogenesis and viability. So if there is a more number of leukocytes, it will induce the ROS, reactive oxygen species, in the ejaculate that will indirectly impact the DNA health of the sperm. So this is the equipment that we will be using in the andrology lab, that is laminar output for aseptic working, and macular counting chamber, centrifuge as you all know, microscope, and the media for sperm preparation and washing buffers, and test tube warmers and incubators to pre-warm are all consumables 37 degrees Celsius. So we have two or three types of processing method. One is simple wash swimmer and discontinuous density gradient. As I have already told you, 80% and 40% of density gradient, where we will be gradually reducing the load of the cells when we are having the pellet, that you will be witnessing in another 10 minutes. That Ashok will give you a demonstration on how the sperm looks in the microscope, and pre-processing and post-processing, how is it looking. So the buffer that we are using is bicarbonate buffer and the Hepis buffer as well, that is having a range of a pH range of 7.8 to 7.8. That not only having the buffer, and it also has energy source, that is glucose required for sperm motility, antibiotics and protein source for mitigating the generation of always. And the density gradient, the method that you will be witnessing, where we will be layering 1 ml of 80% density gradient. Above that we will be layering the 40% of density gradient, and above that we will be layering the seminal plasma. So when we are layering equal volume, 1:1 is the ratio, all three has to be 1 ml. If it is going beyond that, then the layer will get disturbed and you will not have the cleaner bed at the end of the preparation. So once you are done with this density gradient, as I have already told you that there will be 2 layers, and you can clearly see that the layer is being formed, like how a water and a oil shows a distinct layer in between. Likewise you can see in this as well. And once the centrifugation is done for around 1600 rpm after layering, you will have a pellet. That pellet will be aspirated and resuspended in the washing buffer of 2.5 ml. That will be once again spinned around 5 minutes for 1600 rpm, and that pellet will be carried out for either IUI or XC. So simple wash is nothing but you just have to take the 1 ml of sample into a 4 ml of washing solution, washing media, that is buffer, mix it properly, centrifuge it for 5 minutes, then take only the pellet, layer above the herpes buffer of around 0.5 ml, and keep it in a slanting direction. The reason why we keep the slanting position of 45 degrees to increase the surface area. So if you are keeping it in this way, the travel distance to come upstream up is larger, and it is by keeping at 45 degree, you are reducing time of swim up, and you are creating a large number of surface area for the sperm to come up, and where you will have highly motile sperm for the IUI or IUI. Apart from density gradient, we have other, I think it has we have microfluidics for semen preparation where the centrifugation is not required, which is based completely on the fluid activity inside. So this we are using it for ICSI purpose. That microfluidics you can use it for either ICSI or IUI as well. This doesn't require you to do the centrifugation. Just drop 1 ml of sample above that layer buffer solution of 1 ml. In between you will have a layer which is being sandwiched, where only the normal motile sperm will elute from the bottom to the top, and the top you will have a collection chamber here to collect it. The maximum time limit of this whole process is around 20 to 25 minutes. There is another way of sperm sorting, that is MAX. It is a very beautiful, actually this is implemented in cancer biology to only extract the cancer cells, because any cells which is having, every cell is having cluster CD proteins in the surface wall. So by having that, when the sperm is undergoing apoptosis, so it has a phosphatidyl serine, a protein which is protruded from intracytoplasmic to extracytoplasmic. So we might not know which sperm is having a healthy DNA and which is not. So what we are doing here is we are having something called conjugate antibodies that will bind to CD45 and CD235, which is combined with annexin 5, which is having an affinity towards this protein, phosphatidyl serine. So whatever the sperm which is exhibiting the phosphatidyl serine, these beads with conjugated antibodies will go and bind to that sperms, and when you are eluting through a magnetic field, all those which is binded with that antibodies will be trapped on the either side of the wall, and only which is not attached will be eluted, and that will be used for ICSI. So it is a little costly but worth it. That's it. Any questions? Hope you all have understood, or we haven't understood.
So here you are frequently using density gradient.
We treat the sperm based on the motility and concentration of the sperm. We don't treat all the sperms as standard density gradient. So if the sperm is normospermic, we will just directly go with a simple wash and swim up and directly go for ICSI. Or else, if the sperm is having SOA, that is severe oligoaspinoteratome or aspinoteratome, we will be going ahead with density gradient. So there is another way of preparation of teaser sperms also, where we will have to tease the biopsy tissue and we have to take only the sperms. So the processing for that is different. So we treat based on the how the sperm is all about. Same. Fine. Have a nice day.